No other cancer is rising faster at incidence than melanoma. The incidence of melanoma is doubling every 6 years, which is absolutely frightening.
Melanoma has always been one of those tricky cancers for us to understand. And now that we have testing that can really individualize to the patient, that we can really understand their tumor biology, we feel like we can better care for our patients as a whole.
We use genomic expression profiling, we call it GEP, to find out the individual profile of a tumor in a patient to provide individual care and individual follow-up.
Personalized medicine is allowing us to identify those patients who are more likely to be at risk for metastasis, so that we can focus in on those patients, we can personalize their treatments, we can look at them as a separate group, and we can get better results for those patients.
Patients who are thought to be at low risk by conventional tools like the AJCC staging system who are actually at high risk. Conversely, they can identify high risk patients who are traditionally high risk who actually may not be at such a high risk.
So the traditional way of looking at tumor is what we call by histological means, which means looking at certain features, where they're not looking at in-depth genes.
Unfortunately, most of these characteristics were simple observations and weren't necessarily personalized to the patient.
The majority of patients who die of melanoma were actually diagnosed at early stage initially. So in other words, the AJCC tool, which is based on histopathology, is under-predicting.
We tend to think that thinner lesions, or stage 1 and stage 2 lesions, are basically almost immune from any metastasis or recurrence, when in reality the study shows that if you follow these patients long enough, there are a significant number who develop problems.
Well, the good news is that with the new molecular prognostic tests, we are starting to address all those limitations of traditional approaches of assessing a melanoma.
There certainly is a need to refine the selection process for patients who need sentinel node biopsy. As you know, sentinel node biopsy, it's a procedure done under general anesthesia. It's an expensive procedure. There are complications. And we want to try and identify patients who really can benefit from sentinel node biopsy.
We know that it's a valuable prognostic tool. However, it doesn't increase survival. We know that based on the results of MSLT1. We also know that there can be a false negative rate, reported anywhere in literature from 5 to 21%. We also know for our patients, about 88% of them who undergo a sentinel node biopsy procedure will actually be negative, and as a result derive little benefit from the test.
Do they need additional therapy? Is the melanoma going to continue to spread and go to more central organs beyond the lymph nodes? These are things that we don't know, and so sentinel node biopsy is a really useful tool, but it's not the answer in and of itself.
Knowing what a patient's result is for DecisionDx-Melanoma is very important to me, and it empowers me to give that patient individual risk, where traditional methods only offer them population statistics.
DecisionDx-Melanoma has become a very important part of my practice. I use it to inform patients on the risk of a positive sentinel node. I use it to inform them on the risk of recurrence, either high or low.
For instance, we get it on patients when they have negative sentinel node biopsies because we're trying to determine what's their risk of it coming back. We also sometimes get it before the surgery in certain patient subgroups because we want to know if there's still a benefit to even doing the sentinel node biopsy.
All the studies show that about half the time clinicians change management of the patient with melanoma based on the DecisionDx test.
Typically, if the patient's found to be low risk or class 1A, you will see a decrease in intensity of management. On the flip side, if the patient is a high risk or class 2B, you often will see an increase in the intensity of management.
And when you put that information together, you can give them an idea of how well they're going to do in the future, and also what tests need to be done or how much follow-up needs to be done depending on their risk.
Castle Biosciences is changing the way dermatologic cancers are being treated. They're providing us, the melanoma and skin cancer specialty physicians, with molecular prognostic information that allows us to tailor the treatment for a given patient specifically to the genetic signature of their skin cancer.
And the fact that Castle is now dedicated to improving cancer care for melanoma and squamous cell, this is making my job as a dermatologist much more rewarding and providing better care for my patients.
They provide information for patients that helps us make decisions. And the nice thing about that information is that it's not something that we have to get an additional operation for. We don't have to get an additional test for. And quite frankly, it's less expensive than some of the procedures like sentinel node biopsy.
They have changed the view of traditional way of looking tumor and providing more information for us to be more personalized.
Their testing allows us to better stratify which patients are at high risk or low risk for recurrence or mortality from a very serious disease, cutaneous melanoma.
What Castle has done is taken cancers where traditionally we just haven't paid enough attention to them. Patients like melanoma, patients with uveal melanoma, patients with squamous cell cancers, patients where we clearly need more data, more advocacy, more information, and they've taken that on. That's a tough job, and I salute the company for doing that.